So good evening everyone. Welcome to the first session of the clinical ophthalmology case series. So till now the sessions that we are taking, they have the basic instinct for the PG entrance exam and also for the MCQ solving. So now this in clinical ophthalmology case series which I have basically made to understand the ophthalmology. What is the lacuna which we are basically facing? Because of this COVID scenario, the third year students, they are not getting a very good exposure to the clinical cases in ophthalmology because first of all, they are scared to go in front of the patient because in ophthalmology you have to be very close to the patient. And second thing is most of the infrastructure and the human resource is diverted for the COVID management. So in this sessions, what I would tell you is the clinical ophthalmology case series would be very useful for the third year students, for my optometry intern students, and as well as for those students who want to learn more about the clinical part of ophthalmology. So even if you are a PG aspirant or a FMG aspirant, you can basically see these sessions according to your convenience. Okay, so you can see all my lectures on the exclusively on the Unacademy learning app, and you can, if you want, you can go with the Unacademy Plus subscription as well as for the Iconic subscription, where you have the advantage of the Unacademy as well as the Prep Ladder app, where you are getting it at the so decreased prices that you cannot even imagine. Even if you go for a 3-month subscription, you would get 1 month subscription free and use my code OPHTHAL10 to get a 10% discount in any of the session. Okay, there are lots of sessions which are going on like NEET PG Season 1, INI-CT, Target Next 2022 and the FMG Test and Analysis batch from the 5th of May. So if you can appreciate, the first topic that I would be taking on is the red eye. So whenever you see the most of the conjunctivitis patients, most of the patients who are having uveitis or maybe having trauma, they come to the OPD for the red eye. What they have done is they have already gone to some chemist and taken some over-the-counter drugs or even some steroids, and then they come to us. So sometimes the findings are not very easy to see. So in today's session, what we would do is we would see what are the various causes of the red eye, how can we differentiate between the causes of the red eye. These red eye can be asked in your MCQ exam with which of the questions, and what can be the long case scenarios that can be basically presented with the red eye. So let's say you have got a case presentation in your exam that is of the red eye. You have to diagnose the patient, you have to basically do a management of the patient and investigate the patient. So this is the red eye. So if you see the redness, there can be sometimes a blood patch in the conjunctiva, or sometimes there can be a diffuse or superficial or patchy congestion. If you can see here, this area, you are seeing some redness over the conjunctiva. If you can appreciate, just give me a thumbs up. So ये जो लाल लाल सा आपको conjunctiva में दिख रहा है, तो आपको एक diffuse congestion लग रहा है, and there are blood vessels here. Whether they are superficial or deep, how we can basically know it? We can basically know it by doing a slit lamp examination. Okay. So first of all, whenever you get a patient of a red eye, you have to tell that whether it is a diffuse congestion, whether it is a patch of congestion, there is a diffuse redness or patch of redness, and then you have to basically tell whether it is superficial or deep with the help of slit lamp. Okay, then what can be the differential diagnosis of a patient who has come with the red eye? The most important one, I start with the young to adults. So there can be a ophthalmia neonatorum. So let's say there is a 2-week-old child, there is a 3-week-old child, and he has got redness and discharge. The patient may be having a ophthalmia neonatorum. Then we can have various type of conjunctivitis which can cause the redness. It can be viral, it can be allergic, it can be the angular conjunctivitis, bacterial conjunctivitis, and flectanular conjunctivitis. Okay. Then there can be uveitis. It can be an anterior uveitis which is causing a circumcorneal congestion. What is the meaning of circumcorneal congestion? This is my cornea, and around the cornea you have dilated blood vessels. Remember, cornea is a avascular structure. Okay, so cornea में vascularization नहीं होगा. So around the cornea, if there is a vascularization, I call it circumcorneal congestion. You get my point? Then it can be a subconjunctival hemorrhage. There can be a corneal ulcer. It can be because of, again, it can be because of the bacterial, it can be because of the fungal, or it can be because of the viral. Then even episcleritis and scleritis and ocular trauma or any foreign body in the conjunctiva can cause a redness of the eye. Now we would see with the help of some MCQs how these things basically present. Okay, so if you can appreciate this, just give me a thumbs up. So ये हमारी डिफरेंशियल डायग्नोसिस हो सकती हैं. तो एक के बाद एक हम इन डिफरेंशियल डायग्नोसिस को थोड़ा सा डिस्कस करेंगे. So if you want the whole of the lectures regarding the viral conjunctivitis, allergic conjunctivitis, uveitis, you can go to the numero uno in ophthalmology series, or what you can do is you can just download the Unacademy learning app from the Play Store, and there you can just go to the NEET PG section. In the NEET PG section, what you do is you can just go to my profile, that is Dr. Vineet Sehgal, see my lectures, and you can ask me the doubt there also. Okay, so when you see the lectures, you would get the doubt clearance session, you would get credit points which you can use to ask doubts. If you have still not basically downloaded the Unacademy learning app, you can download it from the Play Store and use my code OPHTHAL10. Okay, to basically unlock the free platform. So all my videos you can see free of cost. Chalo, let's move to the circumcorneal congestion. I told you what is the circumcorneal congestion. This is my cornea. Around the cornea you have the congestion. Now Dr. Gopalan, can you tell me what are the causes of the circumcorneal congestion? If you can appreciate any one of them, let's keep this session very much interactive. So I told you circumcorneal congestion, it can be because of uveitis, it can be because of your keratitis, or sometimes even in the acute congestive glaucoma. Okay, so they can ask this as your viva question. So they can ask this as a viva question. What are the causes of circumcorneal congestion? You just remember acute congestive glaucoma, keratitis or any corneal ulcer, and anterior uveitis, they can cause circumcorneal congestion. Okay, chalo, let's move to the questions. How the clinical scenarios of this would be different, and through this we would basically prepare for the PG exam also. So now see, the gone are the days of the one-liner. Now you would be getting systemic ophthalmology and the clinical based question. So my first question is, a patient with circumcorneal congestion and ankylosing spondylitis came to the OPD. Okay, came to the OPD. He most probably is suffering from which of the following? Try to answer. Circumcorneal congestion and ankylosing spondylitis. So Sisha, this session would be very, very useful for you. Also, I would request you that you can basically tell your friends also. When all of you would basically join together, then you would get a lot of enjoyment in basically seeing these lectures. It would be very, very useful for all of you, and let's learn from each other. So very good, Dr. Amog. The answer here is uveitis. So uveitis, which is the inflammation of the iris and the pars pliccata part of the uveal of the ciliary body, this causes anterior uveitis. Now circumcorneal congestion can be in the corneal ulcer also. So why it is not C is the answer? So remember the word ankylosing spondylitis. Whenever you think about ankylosing spondylitis, it is the HLA-B27 positive, and the most common ocular manifestation for that is anterior uveitis. Okay, so the answer here is B. Chalo, let's move to another clinical scenario. A patient with the congestion of eye and mucopurulent discharge came to the eye hospital. He also has complaints of halos which resolve on washing with the water. He must be suffering from which of the disease? So here also the patient has come with the congestion, the redness of the eye. Patient has come with the acute red eye. he is having a mucopurulent discharge, mucoid as well as purulent discharge. He says that he is having halos. Halos come meaning that when he looks to the light, there is breaking down of the colors into the 7 parts. Okay, and when he cleans the eye with clean water, then these halos basically disappear. So what he must be suffering from? So any of you who is a third year student, just write it in the comment section so that I know, and I would basically make this session much useful for you. Okay, so the answer here is conjunctivitis. Now conjunctivitis, uveitis, subconjunctival hemorrhage and corneal ulcer all can be the differential diagnosis of the red eye. Now here there is a mucopurulent discharge. Let's see all the signs one by one. So mucopurulent discharge, can it occur in the uveitis? The answer is no. Mucopurulent discharge, can it come in a subconjunctival hemorrhage? The answer is no. Can it come in the corneal ulcer? Yes, it can happen in the corneal ulcer or it can happen in the conjunctivitis. Now, whenever the patient is having a corneal ulcer, he would also have decreased vision. Okay, the patient would also be having a decreased vision. He does not only have a mucopurulent discharge. There is no history of decreased vision here. But the patient is having halos. Why the halos are coming? Because of the conjunctivitis, what is happening is the mucopurulent discharge, it comes in front of your cornea. So mucopurulent discharge comes in front of your cornea, and when the light rays basically strike this mucopurulent discharge, it basically divides into the various colors. So there are halos that we see, and when we clean the eye with water, this discharge, when it basically decreases, this discharge gets washed off, the halos also gets washed off. Okay, so the answer here is conjunctivitis. Everyone understand this point? Give me a thumbs up. So if all of you, if you have any doubt, you can put it in the comment section. If you are not comfortable with English, you can just write it. I can explain in Hindi as well. Okay, chalo. The next question is, a patient presented with the red patch of eye in the morning. He does not have any pain or redness in the eye. He may be suffering from which of the following? Conjunctivitis, uveitis, subconjunctival hemorrhage or corneal ulcer. Now see, all of them again are the diagnosis of the red eye. So here he is not having a diffuse congestion or diffuse redness. The patient is having only a patch. Okay, so you can see only a bright red patch over the sclera. He does not have any pain, he does not have any redness, and he does not have any discharge. So he may be suffering from. So very good. The answer here is C, subconjunctival hemorrhage. So what happens in the subconjunctival hemorrhage? This is your cornea, this is your sclera, and covering the sclera is your bulbar conjunctiva. Because of trauma, sometimes because of the increase in the intrathoracic pressure, or it may be because of the antiplatelet drugs or even idiopathic, there can be a bleeding or blood collection beneath the conjunctiva. This is called subconjunctival hemorrhage. The basic funda is that there is basically no pain, there is no redness and no discharge here. Remember, whenever the patient is having a conjunctivitis, the patient would have a discharge in the eye. Whenever the patient is having uveitis, the patient would be having not just patch, he would be having a circumcorneal congestion, and the patient would also have a redness, or the patient would also have pain. Then the patient corneal ulcer, the patient would also have pain. So remember, uveitis and corneal ulcer, they are basically differential diagnosis of redness with pain. Okay, conjunctivitis would have redness with discharge and halos. Okay, subconjunctival hemorrhage would be having only red patch, no pain, no discharge and no redness. So the answer here is C. All of you understand? Just give me a thumbs up. So remember, सबकंजंक्टिवल हेमरेज में सिर्फ लाल सा आपको एक पैच दिखाई देगा, इसके अलावा ना कोई डिस्चार्ज, ना कोई पेन, ना कोई रेडनेस होगी. ओके, चल. Then we have the next question like this. A patient with a patch of congestion in the right eye. She also has a dull aching pain. The patient was given topical non-steroidal anti-inflammatory drugs and patient responded well. He may be suffering from viral conjunctivitis, anterior uveitis, corneal ulcer, subconjunctival hemorrhage or episcleritis. Try to answer. So see, what are the various hints given? So the patient is having a congestion. The patient is coming with the red eye. She is also having a dull pain. Okay, तो कभी कभी उसको हल्का सा दर्द होता है. The patient is given topical NSAIDs like Nepafinac, and patient responded well here. What is your answer here? Just write it in the comment section. Even you can give a blind guess also. So very good, Dr. Priya. The answer here is episcleritis. So see, here when the pain comes with a redness and there is a diffuse patch, then the things which can basically happen here is either episcleritis or there can be scleritis or there can be uveitis. Okay, then yes, definitely ulcer can also be an option here. Let's see all the options one by one. So viral conjunctivitis, usually the conjunctivitis and most commonly the viral conjunctivitis, they do not basically respond to a topical non-steroidal and anti-inflammatory drug. A viral conjunctivitis or any type of conjunctivitis, the first sign that you get is a discharge. So सबसे पहले conjunctivitis में क्या मिलेगा? Patient को discharge मिलेगा. It can be a mucopurulent discharge, it can be a serous discharge, or it can be a purulent discharge. So here there is no history of discharge, there is a history of congestion with a pain. Is it clear, everyone? So A, I do not think can be the answer. Now option B is anterior uveitis. Definitely a anterior uveitis patient may come with a congestion and pain, but the congestion, there may be a hint that there is a circumcorneal congestion and not a diffuse congestion. Anyways, it can be a presentation of this also with the anterior uveitis, but remember the patient is responding to the topical non-steroidal anti-inflammatory drug. A topical non-steroidal anti-inflammatory drug would not cause the resolving in the anterior uveitis. What I need in anterior uveitis? I need in anterior uveitis steroids. Okay, so anterior uveitis cannot be the answer here. Then comes the corneal ulcer. Corneal ulcer would be having a more severe pain, not a dull pain. And corneal ulcer would also not respond to a topical NSAID. Subconjunctival hemorrhage, I told you, is not having pain. So the answer basically becomes here the episcleritis, the E. Are you all getting my point? So बाकी हमने options हमने जो है rule out कर दी, हम episcleritis पे आ गए. Now what is actually a episcleritis? So this is your cornea, this is your sclera. Above the sclera we have a tissue which is called Tennant's capsule. Okay, so above the Tennant's capsule we have actually the conjunctiva. So it is the Tennant's capsule is basically inflamed in the episcleritis. Okay, it is not the inflammation of the sclera, inflammation of the tissue which is above the sclera. Okay, so if you can see, there is a diffuse congestion here. Now this diffuse congestion causes a foreign body sensation or dull pain in the eye. The patient is not having a lot of pain, and this episcleritis is either basically getting resolved on itself. So just it is a spontaneous resolution most of the times, and maximum you need topical NSAID, topical non-steroidal anti-inflammatory drug to relieve the pain, or you can use topical steroids like loteprednol or fluoromethalon. You do not need a hard steroid, or you not need a oral steroid in this case, because sclera is not involved. Okay, this is the episcleritis. So remember, episcleritis is a superficial involvement. Episcleritis can resolve spontaneously. Episcleritis does not have too much of pain, just a slight discomfort and foreign body sensation, and episcleritis basically can respond to the topical treatment. Okay, these are the features of the episcleritis. Then we have the next question. A patient with a patch of congestion in the right eye, the deep vascular plexus is involved. Remember, deep vascular plexus is involved. She also has a severe aching pain. She was prescribed oral steroids and immunosuppressants. She might be suffering from which of the following? Your options are viral conjunctivitis, anterior uveitis, corneal ulcer, subconjunctival hemorrhage, or scleritis. So see, those students who have just joined now, we are talking about the clinical presentation of a red eye. How a red eye can basically present in the various diseases. So red eye is a sign, it can be there, lots of differential diagnosis there. So try to answer. Those students who have just joined late, I would be telling you the various differential diagnosis of the red eye can be ophthalmia neonatorum, conjunctivitis, uveitis, subconjunctival hemorrhage, any type of corneal ulcers, episcleritis, scleritis, ocular trauma, or foreign body. Okay, so let's come to the question. So diffuse congestion, deep vascular plexus is involved. Deep vascular plexus is involved. She has a severe pain. Okay, such a pain which can basically cause the patient to get up in the morning or in the night, अर्ली मॉर्निंग. इतना ज़्यादा दर्द होगा कि वो सह ही नहीं पाएगा और एकदम से उठ के खड़ा हो जाएगा कि यार बहुत दर्द हो रहा है यहाँ पे. She was prescribed oral steroids. See, so the diagnosis can be something which is basically immune based, and the patient is also put on the immunosuppressants. Can you see, Ashish? So let's see all the options. Viral conjunctivitis, it is a superficial infection. The patient does not have severe pain. I told you viral congestion comes with a discharge. Anterior uveitis cannot be the answer here. Remember, in the anterior uveitis, there can be pain, but usually it is not very severe, and there is not an inflammation of the deep vascular plexus. I told you there can be just circumcorneal congestion. Give me a thumbs up if you understand this point. तो uveitis में बस खाली cornea के around आपकी inflammation हो सकता है deep vascular plexus involved ना हो. Then corneal ulcer patient would come with the chief complaint of the diminution of vision, and when you stain the patient, there would be a fluorescein staining. Nothing is given here, and you would not prescribe oral steroids and immunosuppressants here. Subconjunctival hemorrhage it's totally no. Subconjunctival hemorrhage does not need any treatment, Ashish. Subconjunctival hemorrhage basically resolves on its own. The last but not the least is my scleritis, which is the answer of choice here. So those students who have not basically attended my Numero Uno in Ophthalmology series, if you want, I would send you the link of the scleritis and the episcleritis in the comment section. You can see how the scleritis and episcleritis basically present. So remember, we have beneath our conjunctiva small vessels. Okay, small vessels, these are called superficial vascular plexus. Superficial vessels. Then around the sclera we have more thick vessels just above the sclera that are called deep vascular plexus. If this is clear to all of you, just give me a thumbs up. So conjunctiva के नीचे superficial vessels होती हैं और sclera के ऊपर deep vessels होती हैं. When the deep vessels are inflamed, this means the patient is having inflammation of the sclera. So patient is having a scleritis here. When the superficial vessels are inflamed, this means the patient is having episcleritis. Now, sometimes it is very difficult even from your slit lamp to see whether the superficial or deep vessels are involved. So in that cases, what I do is I can basically do a pharmacological agent test. मैं एक आई ड्रॉप डालता हूँ आँख के अंदर और मैं ये देखता हूँ कि उसकी जो ये रेडनेस है ये अभी परसिस्ट करती है या चली जाती है. So what I am wanting to tell you, Dr. Priya, that what I do is I basically put a eye drop of a certain category. What it does is it can basically cause the resolution or resolving of the congestion of the episcleritis, but the scleritis remains the same. So scleritis ki redness, this would not get resolved, but episcleritis redness would get resolved. Can anyone tell me what is the name of that pharmacological agent? I use it very commonly when I have to do a retinoscopy of an adult, or I have to basically do a mydriasis of an adult. So the name of the agent is phenylephrine. Have you ever heard the name? Phenylephrine, when we put to the patient, this basically causes the blanching or resolving of the congestion of the episcleritis, but the redness of the scleritis remains the same. This is a very important point. This is so many times asked in the viva. Okay, so examiner है वो पूछेगा scleritis और episcleritis को OPD में, not tropicamide, it is the phenylephrine. So how would you basically differentiate scleritis and episcleritis by a use of the drug? Can be a viva question. Okay. Then there can be another question. A patient who is immunosuppressed came with the redness and watering of the eye and following clinical photograph. He may be suffering from which of the following? Pseudomonas, herpes zoster, HIV or candida. So first of all, what I have done is I am seeing the patient in front of a slit lamp. So remember, the slit lamp is the basic tool which you use whenever you are examining the anterior segment of the patient. What you have done is with the slit lamp, you have basically stained the conjunctiva. Can you see this tear film? This greenish fluorescent tear film? You have stained the conjunctiva with the sodium fluorescein dye, and any epithelial defect, if you can see here, they are taking the fluorescein stain. So these type of shapes, I call it pseudodendritic ulcer. Okay, so tell me what can be the answer here. Now I have given you a very big hint. This is a pseudodendritic ulcer, and the patient is having, so remember, it is not a dendritic ulcer. The difference between the dendritic ulcer and the pseudodendritic ulcer is, in dendritic ulcer you would see the bulbs. You would see the bulbs like this. Bulbs are harboring the virus, and when you see a pseudodendritic, you just see the fern-like patterns, very small and very thin and multiple. Usually a dendritic ulcer is a single. Okay, dendritic ulcer is seen in the herpes simplex keratitis, and pseudodendritic ulcer is seen in the herpes zoster infection. Okay, so you can have a picture like this also, where the patient would come in your OPD. You would see a lot of skin patches and a pseudodendritic ulcer like this. So the patient may be having a herpes zoster infection. So when I end this session, I would show you slides, 4 slides, which you have to take a screenshot. What it means is how you have to present a long case. What would be the presenting complaints? What is the history of past illness? Why the age is important? What is the ocular management that you have to do? What are the investigations you do whenever you see a patient of the red eye? So basically, जब आप वाइवा देने जाओगे तो आपको क्या-क्या चीजें देख के पेशेंट को प्रेजेंट करना है, that would be told in the end of the session. Okay, चलो. Then we have next question. A patient with a diffuse congestion in the right eye. The patient had a vertically dilated non-reacting pupil. deep pain and corneal edema. So one thing more that you are seeing in this patient is यहाँ पर patient को corneal edema भी है और vertically dilated non-reacting pupil है. So it is not only affecting the superficial part of the eye, it is not only affecting the conjunctiva, it is affecting the other parts of the eye as well. So there is a corneal edema also. What can be your answer here? So let's say first is viral conjunctivitis. I told you viral conjunctivitis, there is no pain. Okay, so it is basically out of question. Anterior uveitis, definitely there can be a congestion. Vertically dilated non-reacting pupil, it does not come in the uveitis. Uveitis patients can have pain, definitely. Usually they are having a photophobia as their first sign. Usually they have photophobia, they do not have deep pain, they usually have photophobia and mild pain. Corneal edema, you do not get in the patients of the uveitis. So uveitis can also be not the answer here. Then we come to the option C, acute congestive glaucoma. So definitely the answer here is C. So remember, the vertically dilated non-reactive pupil, this is the most important sign of glaucoma. Okay, and more so in the angle closure glaucoma where you have a very high IOP. This very high IOP causes the deep pain, and I told you in my first slide, it is the differential diagnosis of circumcorneal congestion. So when I end this session today, I would be talking about lots of questions, then you have to answer. Okay, right now I am basically telling you how to proceed in a case, then I would ask you the questions when I end this session. Okay, so be very careful, it would be a very interactive session. Okay, then we have another question. Let's say a 2-week-old child presented with the congestion of the eye and discharge coming from the eye. He also has crepes in the lungs as was in ICU. So patient was earlier in the ICU. He is having a redness, congestion and discharge from the eye. What he is suffering from? He may be suffering from Staphylococcus, Neisseria gonorrhoeae, Pseudomonas infection or Haemophilus influenzae infection. So whenever the question is asked, 2-week-old child, a 2-week-old child does not produce tears. So whenever 2-week-old child is asked, this means that definitely this patient is having some pathology in the eye. The patient is having conjunctivitis. It cannot be a nasolacrimal duct obstruction. And this conjunctivitis, which happens in less than 4 weeks, where the tear production has not started, this I call as ophthalmia neonatorum. Have you ever heard the name? Shiva? I call it ophthalmia neonatorum. Okay. Now, what are the other systemic features that are given here? So, you are having crepes in the lungs also, and the patient is in ICU. Remember, the lung infection in the ICU. So, remember this triad: lung infection, ICU, and red eye in a 2-week-old child. This basically tells the patient is having a infection of the Haemophilus influenza. Okay, so very important is this is a influenza infection. Okay, remember Staphylococcus aureus is not very common in the ICU settings and it does not causes too much. Yes, it can basically cause a lung infection, but such a small child, if you are having crepes, you do not think Staphylococcus aureus. Neisseria gonorrhoeae, you would have basically when you have maternal infections as the targeting agent. Pseudomonas aeruginosa, it usually does not causes the congestion of the eyeball. It usually causes a perforating corneal ulcer, a rapid onset corneal ulcer. It is also not very common with the lung crepes. Okay, so the systemic feature that is the lung crepes and the ICU basically tell you about the diagnosis of Haemophilus influenza. Are you getting my point? So यहाँ पर हमें सिर्फ खाली रेडनेस नहीं देखनी है, सिर्फ बच्चा नहीं देखना है, हमें उसके सिस्टमिक फीचर्स भी देखने हैं. कैसे हम बताएंगे कि उस पेशेंट को कौन सा ऑर्गेनिज्म जो है वो इन्वॉल्व कर रहा है. चलो, Then there can be this redness because of sometimes foreign body embedded in conjunctiva. So if you can see, this was a patient which presented to me few weeks back. So you can see a localized redness. Can you see the localized redness? Give me a thumbs up. So there can be a localized congestion here, and there is, you have seen that a metallic foreign body is embedded in your bulbar conjunctiva. So what I do is, I would come with the management part also, Ashish. So what we would do is, we would just remove this foreign body. And very important is, whenever you see a conjunctiva foreign body, you have to basically do eversion of the conjunctiva as well. What is the meaning of eversion? So this is your eye, you hold it and then you evert it. Can you see here? You hold it and then you evert it so that you can see the palpebral and the fornicial part also. Why this eversion is important? That let's say this is your eyelid and this is your eyeball. Sometimes the foreign body is embedded here, and when the foreign body is embedded here, you do not see it unless you basically evert the eyelid. That's why it is so important, eversion of the eyelid, when you cannot basically tell what is the cause of the congestion of the eyeball. Okay. Then there can be another condition which is called ocular surface squamous neoplasia. If you can see the mass here. So you can see localized redness, but if you can appreciate, there are two vessels which are basically feeding this mass. Can you see? Two vessels which are feeding this mass. So there can be a localized redness. It can be a flectanular conjunctivitis also. It can be a flectanular conjunctivitis also. This also have a nodule which is around the cornea, but the problem is that you do not have the feeder vessels here. So you remove the mass, and after removing the mass you can do a biopsy and see the patient may be having a squamous cell carcinoma there, and then these patients would basically respond to the mitomycin C treatment, topical mitomycin C. If the patient is not responding, you can use interferons. If patient is even then not responding, then you have to basically excise the mass, and sometimes you have to basically remove the eyeball as well. So we have one more question. The question is management of Haemophilus influenza red eye in the NICU pediatric setup. So Ashish, in the NICU pediatric setup, what you have to do is, if there is a ophthalmia neonatorum, you have to basically give the broad spectrum antibiotic eye drops. Okay, I usually prefer chloramphenicol and the erythromycin eye drops in these patients. Okay, so and then you have to basically see that you have to treat the systemic infection. You have to take help of a pediatrician to basically give the systemic antibiotics to the patient. For the eye setup, it basically resolves only with the help of your topical antibiotic eye drops. Okay, chalo. Then we talked about the herpes zoster. Now the question comes that what is the main investigation that you do whenever you have to basically see the patient of the red eye. So you have to do lots of investigation. The first investigation that you have to tell your examiner that you do a diffuse, a comprehensive slit lamp examination. With the help of comprehensive slit lamp examination, why it is important? Through this, you can see the adnexa, you can see the eyelids, you can see the cornea, you can see the conjunctiva, you can see the anterior chamber, you can see the cells, you can measure the intraocular pressure, and you can also see the corneal edema. Okay, so everything, even the fundus, can be seen with the help of slit lamp. This is basically increasing the magnification of your cornea and everything as well. So this is your investigation of choice. What is this instrument? This is called slit lamp examination. Okay, so you do a comprehensive slit lamp examination before going to the final diagnosis. Okay, so if you can see how the slit lamp examination is done, usually it is a dark room procedure, because I'm just showing you, I'm showing you it in the bright light. So if you can see, this is your slit lamp and this is my joystick. So with the help of joystick, I can basically move this slit lamp from one place to another, and I can see both the eyes. I can see the anterior segment, I can see the posterior segment, I can see the cornea, everything with the help of the slit lamp. Okay, very important investigation. Okay, now what can be the long case scenario in this patient? So till now we have discussed about the what are the causes of the red eye, what are the features of the red eye, how basically we have to investigate the patient of the red eye. Now whenever you have to put a long case, how you would put? You would first tell the demographic details. So demographic details, what it means, you have to tell about the age, sex, where is the patient situated, and what is the demography of the patient, you have to tell in the demographic situation. Then you have to tell about the clinical complaints. So in the clinical complaints, you would tell how the patient would come. Patient has come with the pain, redness, okay, how is the redness, it is a diffuse redness or something like this. Then you would tell the patient if the patient is having discharge, okay. So these are the clinical features, okay. Then you would be asked about the history of the patient, the general examination of the patient you have to do, ocular examination you have to do, you have to provide the provisional diagnosis, then your differential diagnosis, you have to tell about what are the investigations that you have to do and what is the management that you have to do. So that is how you present a long case in ophthalmology. Now I would just show you one by one the various features that you have to put. So सबसे पहले demographic. Why the demographic? The examiner would question each and everything. So demographic, let's say the patient has the age of 2 months. If it is a patient of 2 weeks, then your differential diagnosis goes more towards ophthalmia neotorum. If he is a young adult and he is having a back pain, then there can be uveitis. Then demographic, in nowadays the patient is having sometimes red eye because of the COVID also. So you ask the patient that are you there in some place where there are lots of cases of the coronavirus. So if the patient says yes, then the conjunctivitis can be your first feature of the COVID infection. Okay. Then we comes to the clinical features. So redness, watering, pain, discharge and onset, these all are so important as the clinical features. Why this is important? Let's say the patient is having a diffuse redness. So diffuse redness, he may be getting in a episcleritis, he may be getting in a scleritis. If there is a circumcorneal congestion, then your differential features can be different. If the patient is having pain, he may be having scleritis or uveitis. Depending upon the discharge, he may be having a viral conjunctivitis, he may be having a bacterial conjunctivitis, and depending upon onset, if it is a rapid onset, he may be having a pseudomonas ulcer. Chalo, let's move to the next point. So in the history, what are the points that you have to see? So history, you have to basically ask the history of present illness, okay, and you also have to ask the history of past illness. You have to ask that has this happened earlier also? If the patient says that he is having recurrent redness of the eye, what can be your differential diagnosis? Can anyone tell me? So patient को बार बार redness होती है, फिर resolve हो जाती है, फिर redness हो जाती है. So कब हो सकता है ये? If there is a recurrent redness. So recurrence is a very characteristic feature of uveitis. Okay, that's why it is very important. Then personal history, why it is important? Personal history, let's say the patient is having history of ankylosing spondylitis, or the patient is having a history of rheumatoid arthritis, because in these patients it is very necessary to rule out uveitis or scleritis there. Then family history. Family history of COVID, if it is positive, then you think that this patient may also be having a COVID infection and this patient has to be treated in isolation. Then tuberculosis. Why tuberculosis is important in the red eye? Which condition or which differential diagnosis of the red eye can be because of tuberculosis? Can anyone tell me? सो रेड आई में हम ट्यूबरक्लोसिस की हिस्ट्री क्यों लेना चाहते हैं? Remember, tuberculosis history is important whenever we are talking about flectanular keratoconjunctivitis. Have you ever heard the name? So flectanular keratoconjunctivitis में हमारी जो है वो tuberculosis की history is so important. Then contagious. Some diseases can be very contagious. So what the patient says that, sir, I was having this redness in eye in my father or in my brother, and now I am having the redness in my case also. So nowadays, yes, coronavirus can be one of the diagnosis. The other diagnosis can be most commonly the adenoviral conjunctivitis. Okay, adenoviral conjunctivitis, or even in the enterovirus, it is very infectious. Okay, so whenever you see there is a history of the redness and watering in the patients, then you think about the coronavirus, adenovirus or enterovirus. Then there can be a history of trauma. If the history of trauma is there, you do a double eversion to rule out any foreign body. Same happens with the chemical injury. Let's say there is a tuna particle injury. So if there is a tuna particle injury also, you have to do a double eversion of the eyelid so that you know if there is some particle left there in the conjunctiva. Okay, so that's why this history is important. Chalo. Then in the general examination, nowadays so important is you always think about the COVID. Then uveitis. Why uveitis is important? Patient comes and he says you are having a photophobia. You see that there is a uveitis. So you would ask the patient, if it is a young patient, you would ask him about the back pain. If he says no, but he says that, sir, I am having ulcers in the mouth. So can you see, if you are having ulcers in the mouth, genital ulcers and uveitis, what the patient may be suffering from? So my question is, patient is having multiple ulcers in the body and uveitis. The patient may be suffering from a disease which is, have you ever heard the name? Behçet's disease. Okay. Then ophthalmia neonatum. As I told you, the patient may be in the ICU, a 2-week-old child, and the patient is having crepes in the lung, and the patient is having a redness in the eye. So this patient can have ophthalmia neonatum. Okay, so these all can be. That's why total body examination is so important in the patients. Let's say the patient comes and he is having difficulty in basically moving the fingers. So he may be having rheumatoid arthritis also. Okay, so that's why very important is see how the patient comes into your OPD. So उसकी चाल से हमें पता चल जाता है कि उसको दिक्कत क्या हो सकती है. Okay, चलो. Then we have to see the ocular examination. So in the ocular examination, remember this slide. Please take a screenshot of this slide. This has to be done in almost all of your cases. I would tell in the clinical ophthalmology series, all the presentations would be like this. We would discuss how the long case would be basically seen or basically presented. So सबसे पहले हमें visual acuity लेना है. Why visual acuity is important? It would be decreased in the patients who are having uveitis, who are having keratitis, but it would be normal in the patients of conjunctivitis. Okay, it would be normal in the patient with subconjunctival hemorrhage. Okay, so that's why it is very important, okay, to see the visual acuity. Pupillary reactions. Can you tell me in which condition your pupillary reactions would be impaired? I told you when I talked, their patient may be having a deep pain, corneal edema and vertically dilated pupil, not responding. So you can have pupillary reactions impaired in the cases of glaucoma. Then you have to see the conjunctiva. How is the congestion? Is the congestion localized? Is the congestion diffuse? Is the congestion superficial? Is the congestion deep? Or if the congestion is around the cornea. Okay, you have to tell when you present a case that Mr. X, 34-year-old male, came to the OPD with redness and watering in the eye. He had a past history of the attacks, and he has a family history of redness also. On general examination, the patient is having cough. On visual acuity, it was 6/9. The pupillary reactions were normal. The conjunctiva is basically having a diffuse congestion. So that is how you basically present the case. Then you have to see the fornices. Okay, fornices are so important when you are taking the history of any insult to the eye with the trauma or with the chemical injury. You have to see the cornea. In the cornea, you can have a corneal ulcer, you can have a corneal edema, you can have a keratitis, you can have a interstitial keratitis, you can have a endotheliitis. Anterior chamber, why this is important? In the uveitis, you can have cells and flare in the anterior chamber. Eyelids, sometimes even blepharitis. Blepharitis means the inflammation of your eyelids can also basically cause the infection in the superficial conjunctiva. So you have to see the meibomian glands, you have to see the adnexa. Posterior segment, why it is important? Sometimes the uveitis, you can have just anterior uveitis that you see from the slit lamp, but when you do a 90-day examination, you see the patient has intermediate uveitis as well or posterior uveitis as well. So that's why it is so important to do a posterior segment evaluation if it is visible. Remember, if there is a corneal edema, if there is a frank conjunctivitis, you cannot basically do a posterior segment evaluation there. Otherwise, you can do a posterior segment evaluation. Then important is discharge. Why discharge is important? Now discharge can be a serous discharge. Serous ka meaning watery discharge. In conditions like allergic conjunctivitis, like vernal keratoconjunctivitis, you have a serous discharge. In the viral conjunctivitis, there may be a not serous but more of a thicker discharge. I call it mucoid discharge. When you get a bacterial conjunctivitis, you have a more sticky discharge. Okay, I would say more purulent discharge. So the type of discharge also you have to mention when you are taking a history of a red eye. Why this is important? Because if there is a purulent discharge, this means the patient is having a bacterial infection. If it is a serous discharge, this can be a conjunctivitis. Okay, then you have to see membrane or pseudomembrane. What is the meaning of pseudomembrane? Pseudomembrane means that the discharge itself is making a membrane over the epithelium. Okay, so it is not a true epithelium, it is a pseudo epithelium. Pseudomembrane, where we can get a pseudomembrane with the red eye? We can get it in the patients of adenoviral conjunctivitis. The most common type of conjunctivitis, adenoviral. Then you have to see any mass. Any mass, as I told you, can be a ocular surface squamous neoplasia. You have to tell the dimensions of the mass also. Okay, you have to tell the dimensions and the extent of the mass. कितना बड़ा है, कहाँ पर है और क्यों है. If there is a nodule, let's say there is a pinguicula infection, that also you have to see. Also, more commonly in the old age and in a very small child, you have to tell about the lacrimal sac also. Why lacrimal sac is important? Because you can have an inflammation of the lacrimal sac. I call it dacryocystitis. This dacryocystitis would cause the obstruction to the nasolacrimal duct and the nasolacrimal system, and that's why you can have the redness which is more there in the angles of the eye. So that's why seeing the condition of lacrimal sac is also so much important. Then on all this, you tell the patient what is, or you tell your examiner what is your diagnosis. So you say that, sir, on all this I make a diagnosis of uveitis here. On all this I make a diagnosis of provisional diagnosis of scleritis here. I make a provisional diagnosis of foreign body here. Then the examiner would ask you what is your differential diagnosis. So अगर red eye के case में आपको differential diagnosis पूछते हैं, if they ask the differential diagnosis, you would tell my first slide. If anyone wants these slides also, what you have to do is you just download the Unacademy learning app, use my code OPHTHAL10 there. Everything is given in the description. And if you want all these slides or any of the slide, you can just go to the Unacademy Learning app, download it. You can basically see my all lectures free of cost there. Use my code OPHTHAL10, and then when you see the lectures, you would get the credit points. And with the help of credit points, you can ask the doubt to me. You can just put that, sir, I want this slide, I want any specific slide, I would put it in the Telegram group or would send it to you. Okay. So what is the differential diagnosis? Ophthalmia neonatorium, conjunctivitis, uveitis, subconjunctival hemorrhage, corneal ulcer, episcleritis, scleritis और ocular trauma और foreign body, ये सारी आपको provisional diagnosis में डालना है. Okay. Then we have the next one as, okay, then we come to the differential, we have to put in the differential diagnosis. Then they would ask that how would you investigate the patient? As I told you, you always have to do a slit lamp examination. After doing a slit lamp examination, if you think the patient is having a uveitis, you would ask, let's say HLA-B27, you would ask for chest x-ray. Let's say you are suspecting a tuberculosis, you ask for the Montauk's test. If there is a scleritis, you would ask for the RA factor. If there is a discharge and you are basically thinking about a bacterial pathology, you would go with the conjunctiva culture and the sensitivity of the discharge. If you are feeling any mass like a ocular squamous neoplasia, you would go with the biopsy of the lesion. If you are thinking about glaucoma or uveitis, you also have to take the intraocular pressure. So these, remember, most of the work is done. You get 70% of your marks if you go to this level, up to the examination. 10% is regarding your provisional and the differential diagnosis. 10% marks are here, and the rest 20% marks are about the investigation and management. Okay, so see, 80% of your marks are, even if you do not know what is the management. So देखो, this is very important in the clinical part. I am basically a clinician and then a teacher. If I diagnose the patient, the treatment basically depends upon the diagnosis. If you do not do a diagnosis correct, you would not do the treatment correct. Treatment is everywhere same. You have to use some antibiotics, you have to use steroids, you have to do this and that. So treatment everyone knows. A good doctor is which can basically diagnose a disease. Are you getting my point, everyone? So diagnosis करना सबसे जरूरी है, treatment तो हो ही जाएगा. Okay, and what is the management? In the management, what you have to see is that if there is a only conjunctivitis, you can put a topical antibiotics and lubricants. If there is a uveitis, you would use steroids also. If the patient is having glaucoma, you would use anti-glaucoma. If the patient is having a ocular squamous neoplasia, you can use a topical mitomycin C also. So that is how you would basically do a management of the patient of the red eye depending upon what is your diagnosis there. Now, if a student asks that, sir, I want to just within 5 minutes tell me what can be the question asked from me. So long case. So I have been the student teaching in charge of the AIIMS, and I have seen that whenever they give a long case of the red eye, the two most important cases that they give is either they give uveitis or corneal ulcer, where you would have a red eye. So what are the topics that you have to remember regarding the corneal ulcer? So those students who want to basically see each and every topic of ophthalmology, any topic you want, you can put it in the comment section. I would send you the link of that topic. Okay, or you can, I told you again, you can ask me the doubt on the Unacademy Telegram group also. The link is given in the description of this session. You just go to the Let's Crack NEET PG Telegram channel. Let's Crack NEET PG Telegram channel. In the Let's Crack NEET PG Telegram channel, you tag me at Vineet Sehgal. Okay, and just any topic you want, any questions you want, you can put it there. I would try to answer as soon as possible. Okay, so let's come to the corneal ulcer. Whenever you get a case of corneal ulcer, what are the questions they can ask? They can ask you about the corneal anatomy. They can ask you about the layers of cornea. They can ask you about the types of keratitis, viral keratitis, bacterial keratitis, fungal keratitis. They would be asking about the various organisms which can cause the corneal ulcer. So they can specifically ask that, let's say patient is having a pseudomonas infection. What can be the presentation there? The patient is having a acanthamoeba keratitis. What can be the presentation there? They would ask you the complications of the corneal ulcer, like desmetocele, perforated corneal ulcer, anterior staphyloma, endophthalmitis. They all can ask you about the complications. Then they would ask you about the management of corneal ulcer. You have to tell that you would use topical, freshly prepared antibiotics, which are called fortified antibiotics, and you would use a cycloplegic also there. If they are basically a herpetic infection, they can ask you the very important presenting feature. You would tell that there would be decreased corneal sensations in a herpetic infection. Then last but not the least, they can ask you the various types of corneal opacity, nebular, macular and leukomatous. So if any one of you wants the lecture of the corneal ulcer from me, you can write it in the comment section. I would just send the video link for that. Okay. Then the next topic, which is most commonly asked as a long case, that is the definition and classification of uveitis. They can ask you about the anterior, intermediate and posterior uveitis. They can ask you about the difference between the granulomatous and non-granulomatous uveitis. They can ask you about the different types of keratic precipitates. They can ask you about the different type of posterior synechia. What are the complications of the uveitis, like posterior subcapsular cataract, glaucoma, and how they are treated. So the treatment with the help of steroids and where we use cycloplegics, what is the role of cycloplegics in uveitis. So this can be the potential questions that you have to prepare when you get a long case of red eye. So with this, I end my session. Hope you would have liked the session. Shari, black eye. So black eye is basically because raccoon eyes, I tell you, raccoon eyes are there when you are having a trauma or more commonly a anterior cranial fossa fracture. Okay, then you can get a black eye. Okay, so with this, I end my session. Hope you would have liked the session. Please subscribe for our channel, that is the Let's Crack NEET PG. If you have any doubts, you can put it in the comments. And I would also request you that download the Unacademy Learning app. Remember, Unacademy Learning app from the iOS store or Play Store, and see my all the classes there. If you want to see just Ophthal classes of Dr. Vineet, you can get all of them free of cost. Use my code Ophthal10. OPH. Remember, OPT nahi hota, OPH THAL10. Okay, and hit the bell icon for all the notifications. Thank you very much, and I would be back at 10 p.m. with MCQ session on the Unacademy Learning app for the PGS aspirants. We would be talking about very important topic, that is neuro-ophthalmology. Okay, till then,